A very good afternoon to all. I welcome you again to the CCR for the week. I am very happy that it is the Department of Orthopaedics that has been given the opportunity to present the CCR this time. Today we bring to you a case. I wouldn't say that is a very unusual or a rare or uncommon case, but it was approached and managed in a very unique way that led to great clinical results. So let me take you through our peeping tom in the wrist. So an 18-year-old young guy presented to us in our OPD clinic. He complained of some pain over the dorsal aspect of the wrist and also complained of some weakness in the grip strength. He reported that he suffered a history of trauma 1 year back for which no medications or any sort of plaster treatment was taken. We conducted a general physical examination. There was no abnormality. On local examination, we found that there was tenderness over the dorso-radial aspect of the wrist, we commonly known as the anatomical snapbox. The first metacarpal compression test was positive. There was also tenderness over the scaphoid tuberosity, and the patient also had a painful ulnar deviation. We did some specific tests, including scaphoid shift test and Watson test that were painful. The range of motion of the wrist was reduced. The flexion was around 0 to 45 degrees. The extension was 0 to 70 degrees, but it was terminally painful. In our workup, we ordered a radiograph of the wrist, AP and lateral radiographs to diagnose what is the problem. Also, we ordered a non-contrast CT scan to look for the status of associated bones and joints, to look for if there is any fracture gap, cysts, or is there presence of arthritis. An MRI was also ordered to look for avascular necrosis of the bone, because it is very common that in scaphoid fractures the proximal fragment goes into avascular necrosis. This is the radiograph. I would like my radiology colleague to discuss the findings.
Hi, good afternoon, everyone. So on this X-ray PA view of hand, we can see that there is this fracture line through the waist of the scaphoid bone, which is accompanied by sclerosis. The carpal lines, they are maintained, and the radiocarpal joint is also normal. On the lateral view, we can see that the bony alignment is maintained. Now we have these coronal reformatted images of the CT which the patient underwent. So on these images, we can see that there is this non-union of the scaphoid bone. So this is the fracture line which is visible. The margins are sclerosed and there is this accompanying cyst. And the bony fragments, they are minimally displaced, almost non-displaced only. And there is this complete sclerosis of the proximal pole. The lunate and the other carpal bones, they appear normal, and the articular surface of the radius is also appearing normal. Sorry. On these sagittal reformatted images, we can see that there is mild dorsal angulation, and this is the fracture line which is visible. So we were provided with non-fat suppressed T2 weighted and PD sequences. So this is the sclerosed line which represents the fractured part, and both the proximal and the distal fragments, they are showing a homogeneous hypointensity on both these sequences.
Thank you. So the diagnosis is clear here. Basically, it's a case of non-union scaphoid fracture with avascular necrosis of the punctal pole. So if we try to classify this scaphoid non-union fractures, it depends upon the duration, the fracture gap, and the cyst formation and the carpal alignment. So this was in the grade 4, where there is cyst formation, sclerosis of less than 5 mm bone resorption, and normal scaphoid alignment. Why the treatment is needed in these cases? If we see the biomechanics of wrist is altered, there's gradual development of the arthritis, and there it leads to excruciating pain and disability to the patient. So how this happens? Because basically wrist is required to hold the irregular objects for spatial position of a hand. So we see the wrist is a loading articulation in traction. It's a articulation needed during it's a torsion forces also it has to sustain, and for compression forces also. So this is not something, a piece of bones which are lying there. It has a specific function basically. Every bone has, so it has to sustain all these forces without yielding. So if you see this motion, what happens with flexion extension? If you see the proximal pole, proximal row, the scaphoid is the largest bone. So if we move our wrist, the scaphoid gets flexed and the lunate gets extended. So this alignment is just like a musical function in a song. If the music is in a regular way, we'll like it. Otherwise, it won't be a song basically. Similarly, we see the ulnar deviation and radial deviation. We do the ulnar deviation, the scaphoid gets extended and the triquetrum gets flexed. The opposite thing happens with the radial deviation. So the exact alignment of these bones is essential. And the more complicated is the mechanism, that there is high chance of malfunction. That's why we require an integrated normal scaphoid to function the wrist. We see how stability is maintained basically. It's a house of cards. If we just remove a small piece, it becomes unstable. And gradually what happens? The whole house of cards collapses. The similar thing happens in the wrist. Basically, if the scaphoid is fractured, initially a patient will have pain on the unaccustomed activities, sometimes just like playing tennis or lifting heavy weights or golf, taking a ball from the tee, or gradually the patient is not treated, then he will have pain on the weight loading activities. And if it is not, surgery is done now also, then patient will have daily activity just like brushing teeth, combing hairs, just putting on clothes. And if the arthritis develops after 8 to 10 years, then patient will have pain at rest. So treatment is essential for these injuries. In this case, if we see the patient came to us after 1 year, so it's too late. But still, the goal is to achieve the bony union, to restore the carpal kinematics, and to prevent the radiocarpal and midcarpal arthritis. So what are the surgical options here? The first is open reduction fixation without any bone grafting. We just apply a screw and leave it there, apply cast for 6 months or so. Other option is, which is the standard treatment, the most common treatment, where we used to take the graft from the iliac crest and open the wrist and apply the graft in the fracture site and fix it with the screw. The other form is vesicized bone grafting, and the new is the basically arthroscopic assisted bone grafting. So we can take graft, either the cancellous graft, packed graft, or wedge bone graft, or vesicized graft can be taken. It depends upon what small vessel we are taking, whether it's a 1-2 SSRA, all are small vessels when these are around the wrist basically, which can be utilized. So the indication is for vesicized grafting is AVN, failed surgery, non-unions. But still the arthroscopic surgery, we maintain the sleeve. So AVN is one of the indications which is common in both these surgeries. So here we did basically uh, arthroscopic assisted bone grafting, and it's one of the 3 centers in India where we are doing this treatment. This is a certain kind of evolution in these surgeries. So we see an example of just the operation, the surgical branches, what has happened. Initially, the operation theater used to be like this. That's why it's called theater. And gradually, we moved on to operation theater where no tree passes are allowed. We take strict sterile precautions. Everything is quite maintained. And now, where we are moving? We are moving to minimally invasive surgery. So this is the difference basically. If we see, we are moving to a surgery which is especially tissue guided. So this is the only thing permanent in life is change. So we don't know what will happen in 25, 50, 100 years, but things will definitely change. So arthroscopy is not something new in surgery in surgical field. Where people use endoscopes for gallbladder or other surgeries. Similarly, the arthroscope, the same instrument is called arthroscope here. It is most commonly used for knee and shoulder surgery. For wrist and smaller joints, it's still in infancy, and it's done on only a few selected centers. And I'm proud to say that AIIMS is leading in this field. So I'll call it a tissue-specific surgery. Basically, if we need to deal with bone, then we should deal with bone only. We should not touch the capsule. We should not violate the nerves. We should not violate the subcutaneous tissue. If we want to deal with a ligament, we should not touch the bone. We should not touch the capsule or the other things. So this is highly specific surgery, and we hope we will move forward in this direction further. So even if we see, there's no data from our country. If we see from US what is happening, So 7,50,000 knee surgeries are done, and which comes to for shoulder arthroscopy 62 to 71 per 1 lakh per person per year surgery. For wrist arthroscopy, it's very low. It's 3.2 to 2.7 per 1 lakh person per year. So it's the surgery is very rare. So why arthroscopy? There's no donor side mobility. There we don't have to take the graft from the iliac crest. Very small scar, early rehabilitation. We can preserve the soft tissue sleeve, and we have a better cosmesis. And we can definitely see the associated ligament injuries, which may be intrinsic ligament or extrinsic ligament, where the incidence of the ligament injury is 42 to 83%. It also facilitates the entry point for the placement. We can check it whether it's a subchondral or not. So this is the basically disadvantage with the open surgeries, which results in devitalization of the non-union site due to unnecessary stripping, making further complications. So this is added risk basically with the open surgeries that we want to avoid. And for arthroscopy, there is a minimal disturbance of the vascularity, high chance of union rate, a relative short period for bone union compared to open treatment. So what we did basically, we did a debridement. I'll just show the video basically for this case. So we just entered through two small portal directly into the mid-carpal joint. So I'm just putting my needle. So this is the fracture site. I'm using the shaver to it so it becomes more visible. And then the idea is to clear the fracture site. I'm using the hook to identify further and to disinfect these two fragments. We can see the two fragments, the upper one and the lower fragments, the proximal and distal fragments basically. That's why I call it tissue specific surgery. We want to deal with the fracture, then we should deal with fracture. If using a birth, then the RT forceps to disinfect the fracture site. So this is how it will look like closely. And again, the same surgery is done by open methods, but that will lead to stripping of the tissues. And that much of intricacies or that much of fine surgical skills cannot be utilized with open surgeries because the visualization is limited. So this is how it will appear. Then we use the curate to clean the fracture site. This is how it will look like. So we can see the bleeding edge. It is called paprika sign. So bone is visible. We take the graft from the radial sploid itself. This is the graft. Then we use this graft. This is the cannula of the burr. We put the graft into the fracture site through the cannula. And this graft is basically is the healing substance for this bone. And I just compress it with the back side of the spatula. So this is how it will look like once we impact the graft. And then the further in surgery, we take a small screw and fix it percutaneously. So this is how we did. Now the results part, the surgical results are here. Basically, we achieved bone union at 4 months. This is the screw that I have shown and PA with ulnar deviation. These are few views which are done for fracture, PA, ulnar deviation, lateral view, and the supination oblique view and the pronation oblique view. Then we confirm it with the CT scan. These are the coronal sections basically where we can see the fracture is united. Then again the confirmative in the sagittal sections. This is also bone has completely united. But whether these results are correlating with the clinical result, it's essential to see whether because something seen in X-ray and MRI is not equivalent to the patient results. So the grip strength was equivalent to normal side. The range of wrist motion was absolutely equivalent. Patient was able to lift heavy weight and perform push-ups. The scar was surgery was very minimal. If you see the scar, the very minimal scars than compared to the open surgery. So these are the range of motion of the patient, almost complete range of motion of the patient. And I think this is the advantage of tissue specific, tissue preserving, and maintaining the soft tissue components of the wrist. So the patient recently sent me his video where he was doing push-ups. He was able to sustain load. So if we maintain the carpal row that I have shown earlier, we maintain the kinematics of the wrist, then a normal activities can be achieved in these patients. So when one should not do surgeries, basically there is a lack of experience in arthroscopy or wrist arthroscopy. I'm highly thankful to my head, Professor Rajesh Malhotra sir, or the director sir, who has sent me to different places to learn these surgeries. This is only done in few specific centers. There's a learning curve. If we see the review of literature, there's a single case series in literature. There's not this surgery is not very common, and this is done by the 125 cases. These were done by Dr. P.C. Ho. He was my teacher also, and they have shown excellent results in this procedure. So the take-home message for his wrist arthroscopic surgery is current trend setter for scaphoid non-union. There's a ray of hope in new advancement in wrist surgeries, and I am proud to say that the Department of Orthopaedics at AIIMS New Delhi is leading one of the apex uh, center in the country. Thank you.
Thank you, Tahir. Now, since we have finished quite ahead of time, so any questions, any queries? It's quite common wrist injuries, and scaphoid being quite a notorious bone in the sense that if you recollect from undergraduate days that it takes immediately, if I fall today, it will not show in X-rays. It takes minimum 2 weeks, and so that's how naturally it gets neglected. So this case was also 1 year old, so it's a quite symptomatic patients. Oh, oh yes, after 1 year, I mean, he came and you can see the results. Yes. Yeah. Yeah. Good results. It has good results. Yes, definitely. So anyone has any questions, anything, any queries? See, arthroscopy in any centers, evolutions is we start with the major joints, then gradually as we expertise increases and all, we go into smaller and smaller joints. So now we are doing even to the wrist, elbow, shoulder, hip, knee, ankle, shoulder. These are the joints we are doing. Yeah. Spine scopy guided when Jaswal was here that time. I mean, with your departments, we have started that time, but after that, I think it hasn't worked much.
Like PIVD or something.
Yeah, can be done.
Can
Can be. Yeah.
Okay, congrats, Tahir.
Thank you, sir.
If no questions, then I think thank you everybody. Yeah. Yeah. Right.
Exactly the idea behind keeping it is peeping top, because it's just how we are doing. It's a new thing, and just Tom peeps somewhere the window or keyhole. We are going through the arthroscope into the wrist. So it's arthroscopic assisted surgery. That's why the reason behind peeping Tom in the wrist.
When I came to the LT today, I thought the Peeping Tom presentation was by psychiatry.
Yeah, you see that's a very nice thing. You see, so I mean, you'll notice it. Or if you take out those topics, one tries to make it, some secretive or catchy. Yeah. So nice that you came and attended this. Thank you.
If I understand the titles of both the CCRs, I feel very happy that day. Today it was halfway. I could understand the first CCR's title, but I didn't know what was going on with the second.
Thank you.
I think we'll
Thank
call
you.
it. Thank you. Thank you very much.